Well, in the essence of time, we'll go ahead and get started this morning. I'm Eric Mays, one of the project leaders in the IDGI group, and I'd like to thank you on behalf of Ethel Kagan, our assistant director. She's not able to be with us today, but I'd like to thank you again for joining us for the continuation of the IDGI FYI series. Wanted to introduce to you Dr. Susanna Naggie. She's been with us here at Duke since 2002. She's assistant professor in the infectious disease division. If I can get that out this morning. And she's, of course, interested in the patient population that have HIV that are co-infected with HIV. And with that, Dr. Naggie.
Thank you very much. So I can tell my mic is on. In terms of the talk today, my hope is just, the primary population that I take care of are HIV-infected patients, but specifically patients who are co-infected with hepatitis. And primarily that hepatitis, at least here in Durham, is hepatitis C. So about 85% of the patients that I take care of at Duke and at the Durham VA, so I actually have co-infection clinics at both sites, are patients who are co-infected. So I just thought I'd talk to you about, I think you've had a talk, at least one, from the GI group with regards to hepatitis C. So I thought I would try to present this of how is a patient who's co-infected with HIV different than the patient who's affected with hepatitis C alone. And what does that mean as we take care of these patients and as we think about future studies for these patients in terms of hepatitis C therapies or even HIV therapies. So with that, I actually was going to start off the talk with something that I think is a lot of fun, which is I had a recent trip to Kenya in May of 2009, and I had some fantastic pictures. So I thought I'd start that off as I'll end it with a sunset across the Serengeti. We have a nice camera, but this is actually, we were pretty close to these animals, which was pretty amazing. And this guy, I think, wanted to have us for lunch. This guy wasn't interested in it at all, believe it or not. He was actually mostly interested in sleeping. And that was actually a mother cheetah who had to kill and had 2 babies with her. So it's pretty amazing. But anyway, that's just a nice introduction to the talk. So I'm going to do this kind of in 3 sets. One is just to talk about the underlying natural history of hepatitis C as it relates to our patients who have HIV disease. To talk about the treatment of HIV, and not just how do we treat patients with HIV, but what medications that we have for HIV are important in terms of thinking about their underlying hepatitis C disease, and or if you were considering treating those patients for hepatitis C, are there drug interactions that we have to think about? And then talking about the treatment of hepatitis C in our co-infected patients, and how is that treatment different? How are the lengths of treatment different? How are the response rates different? Those sorts of things with regards to the co-infected population. The one thing I will say is I'd prefer for this to be as informal as possible. So, it's a near hour-long talk, and it's in 3 sections. So if questions come up that you would like to ask, I think it's ideal that you ask them in real time because I'm sure other people are thinking the same question, and it certainly wouldn't be interrupting me. So if you have a question that comes up, shout it out, whatever, raise your hand, whatever works for you. But feel free to participate as we go along. So I'd like to just start off with the epidemiology of HIV disease. We know that we have over 1 million infected patients with HIV in this country. We know that we also have 25% of the people in this country who have HIV do not know they have HIV. So getting to and diagnosing these people continues to be a primary issue. The CDC has, within the past few years, kind of sent down a recommendation that all patients between the age of 14 and 65 are screened for HIV, regardless of their risk factors, which would include everyone in this room. And they've actually pushed to say that many patients in this country do not have access to health care. So they don't go to primary care doctors and aren't going to be screened in their primary care doctor clinics. So where should they be screened? Should it be at free clinic sites or free screening locations? Should it be in emergency departments? Sites like that, and that becomes a big topic of discussion. I can tell you that based on the most recent numbers from the CDC, that the most rapidly growing population of patients who have HIV, new diagnoses, are young Black Americans who are MSM, men who have sex with men. And these are generally young men. And it's a clear issue for us because we need to learn how to reach out to this very specific population of patients to educate them about the risk factors and about getting either diagnosed or cared for with their HIV very early in their diagnosis. I can tell you that of the patients that I've had that are new HIV diagnoses in the past year, every single one of them is a young male who is an MSM. And the reason this becomes important for us with regards to hepatitis is that while, if you even look at the current guidelines for hepatitis C, the question as to whether or not hepatitis C is sexually transmitted has always been, I think, a bit of a discussion and a controversy, especially with heterosexual transmission. But we have had now multiple reports of outbreaks in the MSM population in this country and in Europe, which I think raises serious question as to, are we going to start seeing as more of these young men are coming in with new HIV diagnoses, are they also coming in with new acute hepatitis C diagnoses? And that's certainly what we're seeing. Other risk factors that we know about, IV drug use, as we'll see on the next slide, is declining. And the rates of disease related to that risk factor is also declining, which is certainly good news. We're also seeing, and I think there's been ongoing discussion as to whether or not some of the risk that we're seeing in the MSM population is actually related to active drug use. There's not just intranasal, but also intraanal drug use that we suspect changes the barrier, the mucosal barrier of the rectum, and may certainly increase risk of transmission. We know that other diseases of the mucosal barrier, herpes, for example, can increase transmission, and there's significant concern that this behavior in specific populations may also be increasing the risk of HIV transmission, and is an active area of research at this time. So for hepatitis C, obviously 3 times more prevalent in this country, with over 3 million infected patients. And globally, it is a massive problem, and by the WHO has been called a global health problem. So certainly something that is not just specific to our country by any means. Rates of co-infection. So if you are HIV infected, the rates of co-infection with hepatitis C is anywhere from 10 to 30%. And if you look at, and that's just by geographic location. So here in Durham, I can tell you that at Duke, our population of patients who are HIV infected, it's approximately 14 to 15%. If you look at our population of veterans, so just across the street, our rates of co-infection are about 35 to 40%. So we clearly have differences just within risk factor groups. But also in Europe, rates of co-infection are significantly higher than if you took the overall population in the United States. Certainly in IV drug users, again, the primary high-risk group, historically at least, where we have rates as high as 90%. As opposed to HIV, where we have 25% of patients who don't know they're infected with HIV, approximately 50% of people in this country who have hepatitis C do not know. And as opposed to HIV, where there's now significant support to screen everyone, regardless of what they report their risk is, there's much less of a push for that in hepatitis C at this point in time. And that's driven, I think, by a lot of things, including the fact that we previously did not have great therapies for hepatitis C. But I think as we have better therapies that are easier to access, the recommendations for screening for the hep C population may change. This is actually just a nice slide that shows, I guess this pointer, you guys probably can't see this pointer because I can barely see it. But starting this date of about 1989 to 1990, many of you may recognize the significant decline in hepatitis C infection was when we started screening blood products for hepatitis C. And once we were able to identify infected blood products for hepatitis C, we were able to significantly decrease the rates of new infections for hepatitis C in this country. And like I said, now we still see approximately 20,000 new cases per year. And I think the ratio of where that's coming from in terms of IV drug use versus sexual intercourse is going to start to change. This is just to give you an example of the breakdown of co-infection in HIV-infected patient populations. This is from a group out of Johns Hopkins in Baltimore. This is showing in their HIV clinic of patients who were hepatitis C infected, the risk factor for what the transmission of that disease was, whether it's HIV or hepatitis C. As you can see, 85% were IV drug users. And this is very common in Baltimore. Heroin use is much more prevalent than it is in Durham. I have very few heroin users in my clinic. Most of the patients in my clinic smoke cocaine. You can see here that very low rates of heterosexual and or homosexual intercourse as the risk factor. But again, I think we all believe that these numbers will change as we see less IV drug use and we see more risk factors related to sex. Yes.
Sorry. Are you guys noticing that, is there a change over time in people's willingness to report their risk factors for however they're getting their diseases? Is there a change in maybe the stigma of one type of behavior over another one that might be also affecting the numbers?
It's an excellent question. And interestingly, we are seeing that the stigma related to risk factors are very specific to certain ethnic populations. So in some ethnic populations, there's been more openness. In other populations, specifically in African Americans and Latino Americans, there continues to be more a stigma, and many of our young, African American males report that to us. Inability to tell their families, more difficulties with that, more difficulties in coming out about their, sexual preferences, that sort of thing. So, and it's a major barrier. There's no doubt about it. It continues to be. Yeah. So the natural history of hepatitis C, many of you probably know and have heard in one of these talks previously. It is a bloodborne illness, similar to HIV, which is why we do see this run in the same circles. If you're not HIV infected, then and you are exposed to hepatitis C, approximately 75% of people will go on to develop chronic infection, which does mean that 1 in 4 people will be able to spontaneously clear the virus and not have chronic infection. And I will talk to you about how this differs in HIV-infected patients. But it's significantly lower. We know that CD4 cell response is crucial in being able to clear hepatitis C virus. And in patients who are already HIV infected, who already have low CD4 counts, their ability to clear that virus is significantly lower. In addition, there are many, many reports with regards to once you develop chronic hep C infection, what's your risk of actually going on to develop cirrhosis, which is what we are always concerned about. And the reports are anywhere from 8 to 25% historically in the literature. So even if you go on to develop chronic hepatitis C, the risk that you will ever ultimately suffer significant medical consequences, believe it or not, if you look at these numbers of 8 to 25%, is still quite low. And we still aren't very good at identifying who those people are and who's at risk of ultimately developing cirrhosis. Once you develop cirrhosis, the complications related to that are many, one of which is liver cancer. And that's something that I'm going to show you later, as we're seeing in our HIV-infected patient population, as they're living longer from their HIV, that this is becoming a major issue for these patients. So how is this different for HIV-infected patients? I don't have much basic science in this, but this is just a slide to make a point, which is that and my pointer's not working, but the right-hand column, or the darker bar, is patients that are hep C monoinfected. The light bar is patients who are HIV co-infected with hepatitis C. And this is just showing you immune responses to hepatitis C disease. And you can see that patients who are co-infected have significantly lower immune responses to hepatitis C. And this is part of the explanation, as I already mentioned, as to why these patients cannot spontaneously clear hep C. So if you have an HIV-infected patient who gets exposed to hepatitis C, their chance of clearing the infection is about 5%. So as opposed to 25% chance of clearing, it's a significantly lower chance. So this is the first study, as far as I know, that was published actually out of Wales and the UK for recognizing that patients who are HIV infected are higher risk for having significant liver disease if they also have hepatitis C. And of course, this study was done in the hemophiliac population, which was one of our first populations where we recognized HIV hepatitis C co-infection. So these were in, most of these patients obviously are men. All of these patients are men, I should say. And they were infected when they were young boys, getting blood transfusions. And the two areas that I'd like you to look at is just under liver disease. The left-hand column are patients who do not have HIV. The right-hand column are patients who do have HIV. And this is compared to the general population in that country. So if you have hepatitis C but not HIV, your risk of developing liver disease is almost 20 times higher compared to the general population. This is what we know about hepatitis C. If you were HIV co-infected, your risk is 94 times the general population. So this is a significant, very clear significant difference in terms of the rates of liver disease in HIV co-infected patients. Since that time, there have been many studies in every country that I could possibly name, or at least in most countries, that have shown that patients who are HIV co-infected have significantly higher rates of progression of their liver disease. So as opposed to that 8 to 25% that we talked about historically, we know those numbers for HIV-infected patients are significantly higher. So this is actually a meta-analysis that was done out of studies all from the United States. And all this plot is to show you is that the names are the first authors of the different studies. The boxes just show you the size of the study and the number of patients. And what this is meant to show you is that if you are HIV Hep C co-infected, your risk of developing cirrhosis as compared to a hepatitis C mono-infected person is 2 times. Okay, so twofold the risk. Your risk of developing decompensated liver disease, this is not just cirrhosis, but now you have, ascites, and now you have jaundice, and now you have risk of bleeding and all the other complications that go along with this, and this goes along with a 62% 5-year mortality, is 6-fold higher. So clearly this is something that's of significant concern to those of us who take care of HIV-infected patients. So this is the DAD study. Those of us who do HIV disease, this is kind of one of our big landmark studies. It involves almost 24,000 people from 11 countries. And all this was that any patient who came into the clinic who was getting care were just followed long term. So there was no intervention in this study. And all they wanted to know was, what do our patients who have HIV die from? Okay? This study started in the late 1990s. So at that point, we actually did have antiretroviral. So this is in what we call the early antiretroviral era, and was continued at this point through 2004, okay? And what you can see was AIDS, well, technically other was the leading killer, and no one really knows what other is, but it's a significant interest to most people at this point in time and a lot of research. But the number 1 killer was AIDS, and that was not to be unexpected. But when the second leading killer was liver disease, I think people were quite surprised. The actual hypothesis of the study was that patients would be dying from their heart disease. Because we did know that some of the antiretroviral therapies were increasing people's risk of heart disease, which was the second leading cause of death. But liver disease was, I think, something that no one was expecting to find. So this is a landmark study that most HIV talks will have in it, because this shows, I don't know if you guys have ever seen, there's a chart that looks at all medical therapies in the history of the human race. And it shows the benefit in terms of lives saved. And if you've ever seen this chart, then you would know that HIV therapies is of all medical therapies, better even than penicillin in terms of saving lives. And I think the medical therapies that are on that table are HIV therapies, penicillin or antibiotics, open heart surgery for CABG and bypass, and bone marrow transplant. And the benefit for HIV therapies has been unbelievable. And it's been amazing that it's kind of happened in most people's lifetime. So what this shows is that once we actually had protease inhibitors, the rates of death from HIV disease plummeted. So as that happened, something very interesting for our patients who were co-infected occurred, which is that, and as you can look at this slide, and I apologize, the pointer isn't working, but in 1995, this was in the very early ART era. This was when we only had AZT, basically. So really weren't really saving that many lives with AZT alone. But if you look at this, you can see that 92% of patients died related to their AIDS disease, or related to AIDS, and very few of them were dying from their liver disease. So that makes sense, right? Because they weren't having a chance for their liver disease to cause a problem. But you can see as time moves on, and the most recent show is from 2005. This was actually published just, I think, last year or 2 years ago. Yeah, actually 2009. Shows that now 35% of our patients are dying from AIDS or HIV-related disease, and now 17% are actually dying from their liver disease. And that has remained quite constant. So it's not that this is increasing it's continuing to increase. This is a large number of our patients who are dying from liver disease. And I think previously, I will say this, I'm a new HIV provider. I've only been out of training, technically ID training, for about 7 months. But if you look at the providers who have been taking care of HIV patients for 30 years, to them, hepatitis C was never a problem, because so they didn't think about hepatitis C. They didn't consider treatment for the patient's hepatitis C because they knew that wasn't going to kill them. Now, as these patients are living longer and doing so much better, we have to start changing the mentality within HIV, which is that now these patients' diabetes and their heart disease and their obesity and their liver disease is something that we really need to start addressing, because that's ultimately now what's going to take their life. It's not going to be their HIV disease. I mean, I can probably tell you on one hand how many patients I have in my clinic currently who have AIDS. Most of my patients, whether they actively use drugs or not, have very well controlled HIV. So it's really a new world for many folks who have HIV, at least in this country, maybe not in others. So this slide is just to show you, to kind of reiterate the idea of liver cancer. So this is actually a study looking at non-AIDS-related cancers. So not lymphomas that we think about, non-Hodgkin's lymphomas that we think about, or Kaposi sarcomas that we think about in HIV, but liver cancer alone. And it's the 4th leading cause of cancer in this patient population. And liver, in my opinion, liver cancer is preventable in that we can screen for it. At least death from it is preventable. We can screen for it very easily, and we can cure these people with radiologic interventions, not even surgeries if they're identified early. And I can tell you that of my patients who have passed away in the past year, 2 of them died from hepatocellular carcinoma because they were referred to me once they were already diagnosed and it was too far gone. And the one sad thing about co-infection, at least in most of this country, is that these patients are primarily not offered liver transplant. No matter how well controlled their HIV is, they currently are not offered liver transplant. And I think that there are very few centers in this country who will offer them transplant. Duke is not one of them. So this is the SMART study. And this, again, just the point to make here is that the SMART study was just a study looking at outcomes in our patients who were initiated on drug therapy. The question really became, now that we have so many drugs, when do we give them to the patients? Do we give them to them right away, or do we wait until they cross some threshold with regard to their CD4 count? Because, giving these drugs, long-term exposure to these drugs, we know have some significant side effects. Lipid problems, increased risk of diabetes, increased risk of cardiovascular disease. What we also now know is that probably chronic viral replication also increases your risk of heart disease. And interestingly, we now know that HIV and Hep C infected patients have a higher risk of heart disease if they do not have controlled viral replication. So it's a bit of a catch-22 with our antiretroviral therapies. But you can see here, and this is a much more recent study. So this was in the new, what we call the highly active antiretroviral therapy era, where we now have multiple drugs. This is the cocktail era that we have now. And I think even in the past 2 years, we have new drug classes that I'll talk to you about that have really changed, I think, long-term outcome for our HIV-infected patients. But you can see here that a lot of these patients were dying from this non-opportunistic disease cancers, and a lot of these were liver cancers. You can see less that were clearly related to just liver disease, but a lot of these were related to liver cancer alone. And as a matter of fact, in this study, there were very few patients who actually had hepatitis C coinfection. But of the patients, so the patients who had hep C coinfection were less than 10% of the entire population in the study, but they contributed over 50% of all of the outcomes, which is a major problem. So this is just to show you, this is actually a small study that I did with Andrew Muir here in the DCRI, which is just looking at our patient population here at Duke. And why patients that are Hep C co-infected versus patients that are HIV mono-infected, why do they get admitted and why do they come to the emergency room? And what is most interesting, you can see this here, if you look at our co-infected patients are the ones in the light blue, and if you look at hospital admission, HIV is actually one of the lower reasons for them to be admitted to the hospital these days. More likely reasons are that they have a psychiatric admission, a renal admission, issues with their diabetes, or an infection that's not related to their underlying HIV disease. I think just reiterates the new world that we're in when it comes to HIV disease. And this is showing you that as our patients, again, this is kind of reiterating the same thing, so it's probably getting boring, but the pink is AIDS, the red is end-stage liver disease or any liver disease, and the green and yellow are other or cancer. And you can see that as time goes on and as these patients do better, they're starting to die from these other things. Okay, so any questions with regards to that or comments? No? Okay. So the next thing is just to talk about HIV and how do we treat. I don't know if you guys have had any talks as of yet about HIV as a whole. I don't think there are many HIV providers here through the DCRI, so my hope was that you hadn't, so that this wouldn't be all out of review. And hopefully it's of some interest to you. So a lot has happened in HIV, even in the past few years. So we've had multiple new drug classes that have come out as available therapies. So in that, most guidelines probably change every 5 to 10 years, generally speaking. In HIV, the major group that releases guidelines, the DHHS, has released the guidelines 3 times in a 1-year period. And that's because things have changed so much based on the literature that's been coming out. And most of that is with regards to 1, new drugs, and 2, when do you start treating these patients? When we had only AZT, the goal was wait until they get really, really sick, and then you try to pull them back from the abyss for some period of time, usually a couple of years, by giving them a drug to get their CD4 count up. Because we only had 1 drug, and the development of resistance, as we're learning in hepatitis C now that we're trying to do directly active therapy, is that resistance develops, and it develops pretty quickly. So when you only have 1 drug, you want to use it when you have the best chance of actually making a difference. Well, now we have a lot of drugs. And, in the 1990s, someone taking a cocktail, which was, some protease inhibitor, and some nucleosides was usually on average, 26 to 50 pills a day. No joke. And this was multiple dosing, and they had to be taken with meds. Some of them had to be taken with food, and some of them without food, and some of them 6 hours after they ate, and and it was really crazy. And the idea that any patient could maintain that sort of rigor was, I think, ridiculous. So now we have drugs that are 1 pill once a day, which is amazing. So 3 pills in one. And it's a whole new world. And we actually have patients. I have many patients who were on AZT monotherapy, and they're alive and doing very well today with very few pills, and they've seen this whole thing happen. They've lived it, and it's pretty amazing. But the question now is kind of come full circle. So back then it was good. You waited until the CD4 count was low, and then you gave them the drugs you had, and you tried to buy time with what you had. So now we have lots of drugs, and people tolerate them extremely well, and we're talking about, if you can get the 1 pill once a day, great. If not, your other option is 3 pills once a day. Or maybe it's 2 pills twice a day, but this is still reasonable. This is better than what patients have to take for their heart disease, So now they can take them, so the risk of resistance is significantly lower, and they can take them for a long time. So now the question becomes, when do we start? And do we have any idea whether it's better to start sooner? And is there some detriment to having this virus replicating in your system? And as time goes on, we're learning more and more that the answer is probably yes. So the guidelines have recently changed. When I started practicing, we started CD4 counts less than 200. So you let people get all the way down to 200, and then you pulled the trigger and started treating them. So more recently, we have very clear randomized controlled trial evidence that says 350 should be the new cutoff. Beyond that, we have 2 very large observational studies that actually say 500 should be the cutoff, and actually one large study that says you should start treating these people as soon as they feel that they can start doing this, because this is treatment for life, as opposed to hepatitis C, or when we treat these people, we're treating them for a limited period of time, and we're trying to achieve a cure of their virus. Similar to hepatitis B and HIV, we don't cure these people, so this is treatment for life. So once they go on these pills, they have to realize that they cannot come off. And that study has been done. Put them on drug and get their CD4 count above 400, and then take them off and let them get down to 200, then put them back on drug. And that's what that SMART study told us, was that doesn't work at all. So now the new cutoff is 350, but you'll see here that the guidelines clearly say in someone who's co-infected with hepatitis, there is probably benefit to actually being on drug earlier. And that's because we know, as we said before, that this CD4 count really is important for people to control viral replication, and probably plays a significant role in their risk of going on to have liver disease. So this becomes a big issue for me because I tend to favor starting these people, any of my patients who are co-infected, at a CD4 count of 500. And I have these discussions with my patients every day, regardless of their educational level. Patients want to participate, and they want to know. And most of them, my experience has been, is I want to be on drug, doc. I don't, if I can have this virus at 0 in my bloodstream, that's what I want. And we do have significant fatigue and things like that are also related to these patients who have chronic viral replication. So this is actually the NA Accord study, which is the big study that actually showed, as you can see here, this is deferral of antiretroviral therapy to a CD4 count less than 500 versus starting before they ever go below 500. And you can see here that this is the risk of death. This is of death. And it's almost twofold, 1.94, right? So almost twofold that if you start above 500 versus less than 500. That's a pretty big deal. This is not, risk of chest pain or even a heart attack. This is risk of actually being dead by the end of the study. So what are our options? So like I said, in the early 1990s, we had one drug, then we had another one, then we had another one, and now we have a ton. And in the past 2 years, we have 2 new drug classes, and actually within the next year or two, we're going to have another new drug class coming. So for those of you who do hepatitis C work, I feel I wasn't around during this era, but I feel like I'm seeing it happen in hepatitis C right now as they're doing these directly active drugs, or the stat C compounds they call them. That's what this is. I mean, I think the only difference is because this has been done in HIV already, one is hopefully we will learn from the mistakes made in HIV disease back then. And 2, things are happening a lot faster. So, what took people time to get these drugs to the FDA are probably going to happen a lot quicker, which is great because we have many patients who could benefit significantly from these medications. But all I will say, because I may mention some of this in the rest of the talk, is that we basically have, so we really have 5 new drug classes, technically 6 new drug classes right now. One is no longer used. It was a shot called T20, and it was our rescue therapy. Once someone was resistant to everything, this is our last chance to bail them out. We now do not have to use that drug anymore because we have new drugs that have been able to replace it, which is fantastic. But the biggest ones are the NNRTIs, or the non-nucleoside reverse transcriptase inhibitors. We have the NRTIs, or the nucleoside reverse transcriptase inhibitors. So, nukes are going to be, we're using, for Hep C agents, we're using nukes. They're just polymerase inhibitor nukes instead of protease inhibitor nukes, right? So this is all very similar. And then we have the protease inhibitor group. And this protease inhibitor clearly is very different than the protease inhibitor for hepatitis C, so there doesn't seem to be any interaction between the viruses at this point in time, although there's been little study, and those studies are ongoing. So atazanavir, darunavir, fostemprendavir, Kaletra, these are the drugs, the protease inhibitors that we now have and that we now use. And usually you're combining an NNRTI or a PI with an NRTI backbone. So it's always 3 drugs, except for a drug that I'm going to tell you about, which is called raltegravir, an integrase inhibitor, and that can be used alone with an NRTI backbone as well. So generally, these are 3 drugs that they're getting, and they're either getting them in a single pill combination or they're taking them with a couple of pills. So it's a very nice combination. So the reason I put this slide up is that the next few slides are going to be talking about the problems that we have with antiretroviral drugs in the liver and the risk of putting these people on these drugs, because these drugs cause hepatotoxicity. And I think some people would question, is it worth it? And I think the answer is obvious, because we saw that earlier slide of how this saves lives. But this actually shows you of liver-related mortality. If you are a patient on highly active antiretroviral therapy, which I would say started in 2001, then your chance of dying from your liver disease is actually very low. So this kind of shows you how some of those slides I showed you that were really covering the earlier years in the late 1990s to early 2000s are very different. If you are a patient who got no treatment, then your survival related to liver disease is very, very low, right? And if you are on antiretroviral therapy, this was the early drugs, so not the cocktail therapies or the newer therapies, you can see that there was a difference, but it wasn't a huge difference. So this is a big gap that we've made. Not me by any means, but that has been made in medicine related to the newer drugs that we have available. So this just goes into the idea that when we give these patients HIV drugs, there's a risk that we could cause liver problems. And some of the older drugs had a lot of liver problems, and a lot of our patients who were co-infected couldn't tolerate them, which was a really miserable situation because they were some of the patients, certainly not that they needed them more than anyone else, but they certainly needed them. And this just shows you that the discussion of when we put someone on a new drug, they can develop elevations in their ASTs and ALTs. And anyone who's asymptomatic and has less than 5-fold, we can kind of watch them and see whether or not their numbers trend down. Once they become symptomatic, where it's greater than 5 times the upper limits of normal, we have to make decisions on whether or not we have to stop their ART therapy. And this becomes a big issue because if they're on drug and then we have to stop their drug, their risk of resistance becomes very real. And that's something that you really don't want to have to do unless you really have to do it. So this talks about some of the drugs that we currently have and the interactions that they can have with the liver. So nevirapine is a drug that you may also hear about. This was the first drug that was really studied in pregnant women. This is a drug that was given to pregnant women so that they could prevent transmission to their child. And it works unbelievably well. The issue is that it causes significant liver disease and high rates of hepatotoxicity. And this drug is still used quite frequently, especially in developing countries. So one thing that doesn't get discussed in developing countries very often is we're still giving a lot of drugs that are hepatotoxic, and we have no idea what the rates of hepatitis C are in most of these countries, or hepatitis B. They're not getting screened for their underlying hepatitis. And we have no idea what kind of damage we're causing to these patients' livers as we're doing this. Mitochondrial toxicity is very common, diadenosine and stabudine, D4T, DDI. You know how back in the day all these drugs had like 10 different names. So we're doing that less and less these days, which is good for the new providers like myself. But these are drugs that really cause significant liver disease and actually in studies have been shown to increase risk of fibrosis and cirrhosis in patients who have underlying disease. But these are drugs, so I still every once in a while get a patient who's on one of these drugs, especially in the VA system, and these are patients I'm having to take and get off the drugs and put them on newer drugs and newer agents, and luckily we have plenty of those, so my life is not that difficult. So this is just something I wanted to show you. Ritonavir, I don't know how many of you know of the drug ritonavir. Those of you who do hepatitis C work, you're going to start hearing about it more and more. Ritonavir was one of the first protease inhibitors. And while it worked extremely well and saved a lot of lives, it caused a ton of liver disease. So you can see here, ritonavir is in the top, the black bar. And if you look at rates of grade 3, 4 hepatotoxicity, this is greater than 5 times upper limits of normal AST, ALT. It's the primary drug. This was back when we used to give 600 milligrams twice a day. So to put it in perspective, it was so poorly tolerated, it had so many problems with the liver, that it is no longer FDA approved for treatment of HIV. It is now FDA approved for boosting of other protease inhibitors. So it is now specifically only used as a metabolic booster for other protease inhibitors. So whenever we give atazanavir or darunavir, and Kaletra is actually a combo pill of lopinavir, a protease inhibitor, and ritonavir just to boost. So, interestingly, the protease inhibitor work that's now being done in hepatitis C, we're finding that as opposed to doing Q8-hour dosing, if you give them a booster, and ritonavir is going to be that booster at least for some period of time, those patients can go on once daily dosing. So it's actually now being used, and I know it's being used by some companies in their early PI studies for hepatitis C. So this is a drug that if you do hepatitis C work is definitely going to be something that you'll start hearing about. And the issue is that ritonavir, so at lower doses, so the boosting dose is 100 milligrams. And at lower dosing, it does not have the significant side effects of the liver, but it does still have significant increased risk of hyperglycemia and ultimately likely development of diabetes, like many of the other protease inhibitors has. So and I don't think it's going anywhere. I know GSK has developed a drug that's going to be a booster similar to ritonavir, but we have no idea. It may still have the same side effects. So these are all things that we certainly have to consider as we start giving these patients these medications. So of these drugs, as I said, not only, in my opinion, is adenosine and cytidine contraindicated in people with liver disease, but it's definitely contraindicated if you actually want to treat patients for their hepatitis C. So as I first start seeing these patients, generally I'm looking at their ARTs and saying, which drugs do I need to get rid of? And how do I need to change these patients over? Because once we change them, we have to follow them very closely for several months to make sure that they suppress and that we don't cause problems with their HIV, which to me, if I had to choose about which one's going to be better controlled, obviously it's going to be their HIV disease. That's going to come first and foremost. So I think I'm going to skip through this and just move to the new drug classes really quickly. So this is just a schematic of all the different drug classes that we have and where they act. So I've gone through reverse transcriptase inhibitors, right? So we have nukes and non-nukes. Protease inhibitors, which is this post-translational processing. This is just taking that big, long protein and chopping it up so that it actually is a functional virus. So those were our two primary classes, right? Protease inhibitors and reverse transcriptase. So now you can see, remember I told you the T20? That was a fusion inhibitor. So similar to, I think, hepatitis C work, we know so much now on the cellular level of how this virus works. So this is something that's kind of amazing, and I just think it's very interesting. So this is the virus this is the CD4 cell, right? This is a lymph cell. This is an immunologic. It's the way that we fight off infection. So it binds to the CD4 cell. It binds to this antigen on the CD4 cell. So we used to think that that's the only way that it bound. What we now know is that when it binds, it has two other receptors that it has to bind to. One is called the CXCR4, and one is called the CCR5. I don't know if you guys have ever heard these, but the CCR5 actually plays a role in hepatitis C disease as well, which is very interesting. So what's most fascinating is 1% of the Caucasian population in this country does not have a CCR5 co-receptor, which means they are immune to infection with HIV. And those people are of great interest, obviously, to us as researchers. So what's fascinating is that we have what we believe is the first cure of HIV that was published in the New England Journal about a year ago. This was a patient who had leukemia. He was HIV infected and had leukemia, very well-controlled HIV. He had to get a bone marrow transplant for his HIV, and he was transplanted with a patient who was CCR5 negative. And he has not needed HIV drugs for 2 years, which is really amazing. Now, I'm not recommending that we transplant all HIV-infected patients. I don't think we can afford that. But it does give us some insight into how we can start other mechanisms by which we can, one, treat these patients, or two, identify mechanisms for vaccine, obviously. These co-receptor blockers are actually, now that we know that this is a receptor, we can actually develop inhibitors that bind to that so that the virus can't bind. And we now have, so the most common one that we use is Maraviroc, but I'll talk to you about why that one is not ideal for our Hep C infected patients. So the other drug is raltegravir. This is an integrase inhibitor. So basically, once the virus gets into gets into the CD4 cell, it has to, it's made into RNA, and then it has to, or RNA and then DNA, and then it has to be inserted into our genomic DNA. So as opposed to hepatitis C that does not insert itself into our own DNA, HIV and Hep B both do. So this prevents it from doing that. And this drug is, I'll be honest with you, I don't get paid any money from any company. And this is an amazing drug that has really changed the lives for many of our patients, mainly because the protease inhibitors and the reverse transcriptase inhibitors were the ones that have all come up kind of over time, so resistance has kind of gone along with that. So this was the first real drug class that no one had been exposed to these. So our patients who had resistance to every class and they were getting this shot, the T20 shot, and we really thought they probably had a year to live, suddenly we got this new drug. We're going to take you off this shot and put you on this new drug, and their viral loads are suppressed, their CD4 counts are going up, and they basically have been given a new lease on life, which is pretty amazing when you think about it. And then this maturation inhibitor is actually a drug that's currently in phase 3 study and should be available within the coming couple of years. So it's pretty exciting. So the only thing I wanted to say about raltegravir, and the reason I'm saying this because it is an HIV Hep C talk, is while we know how these drugs work and we have lots of interesting information about them, we have no idea, now that we have so many drugs, which drug is better for which person. And that we don't know. And those are the studies we don't have. So now that we have them all, I think this becomes the question is, we know these drugs can cause diabetes. We know that some of them can cause non-alcoholic fatty liver disease that can increase their risk of fibrosis and cirrhosis. So are some of these drugs better for our patients who are co-infected? Should we not be giving them some and be giving them others? And I believe, just based on some of the early data, that raltegravir may very well be one of the drugs that is best for our patients who are co-infected. Part of that is, one is whenever they do studies for HIV drugs, who do you think they exclude? People that have hepatitis. And of course, when they do hepatitis drugs, who do you think they exclude? People that have HIV. So, but slowly but surely, we're starting to get some press, I think. So, in this study, they actually, there were, I think, about 17 patients who were Hep C co-infected. But of those patients, none of them developed abnormal AST, ALT on this drug, and which I think is actually great. And then this is actually a study that was presented by a Spanish group where they had 311 patients, and 92 of them were co-infected, and they all were on raltegravir. And they actually found that grade 3-4 abnormalities of liver, their AST, ALT was 3%. So this is the lowest of any ART drug that we have available at this time, which I think is great, and I do believe that if I were involved with raltegravir, I'd be giving them high recommendations to start studying this drug in patients that are co-infected. So Maraviroc, the only thing I'm going to say about this is, so this was the CCR5 co-receptor blocker. So the initial studies in animals actually caused significant liver damage and fulminant liver failure. So the first drug was actually pulled off the market because once it went to humans, it showed the same thing. Maraviroc actually did very well with regards to that, but you can see in Hep C infected patients, grade 3, 4, 10%. So you're weighing raltegravir, which is 3%, versus Maraviroc, that's 10%. And to put it in perspective, the other drugs that I primarily use, the protease inhibitors, atazanavir, darunavir, are somewhere around 6 to 7%. So they're kind of right in the middle. All right, so the last kind of 10 minutes, I just wanted to go over management and treatment of Hep C as it relates to HIV, because I think most of you guys have heard the talk on treatment of Hep C. So predictors of therapy, and there's actually lots of great data that I can sit down with a patient when I talk to them about starting them on treatment for Hep C, and I can basically sit down and tell them, based on the information I have about you, okay, what your ethnicity is, what your gender is, what your genotype of hepatitis C is, what your viral load of hepatitis C is, and whether or not you're co-infected with HIV, I can give them a good idea of what their chance of cure of Hep C is before they ever start treatment. Now for me, because the patients I take care of, it's usually not a great talk. I'm usually telling them it's going to be about a 20% chance. But, for them, a 20% chance of cure in a disease, as you guys saw, that may cause significant risk of death down the road is worth a try. So viral load is something that we talk about a lot. Genotype is something we talk about a lot. And as many of you probably have heard, I believe maybe Alex talked about this, but John McCutcheon and David Goldstein's group published IL-28 polymorphism data that showed that it now is the strongest predictor of response to therapy in Hep C mono-infected patients. So now the ability to sit down and talk to that patient's gotten even stronger to be able to explain to them, one, not only what their chance of response is, but two, probably what their length of therapy is going to be as well. So those people that maybe aren't IL-28 who are genotype 1 are probably going to have to get treated for 72 weeks, which is a year and a half of therapy, which I've never been on interferon, so I don't know what that's like, but having watched my patients go through it, I know it's not easy. So this was actually just to show you, but I'm just going to move through this. So just to put it in perspective, so genotype 1 of all the viral types is the one that responds least to therapy. We know that for sure. And if you look, this is actually in the HIV-infected population, so only in HIV-infected patients. If you add up all the different genotypes, then genotype 1 is somewhere around 85%. So, their chance of response based on their viral load is around 20%. So like I said, most of the patients I'm treating are going to have a poor chance of response, but not a 0% chance of response. And believe it or not, most of these patients want treatment. They want to try. So when we had the talk, and I think probably many of you have heard this before, but in terms of length of treatment, this is where it gets a little interesting. If you look at the AASLD guidelines for Hep C monoinfection, there's a very small blurb about co-infected patients. The current recommendation, because the only data we have, is that anyone who's HIV infected should be treated for a year minimum, regardless of the genotype that they have. So if you're HCV monoinfected, you're genotype 2, then you can get treated for 24 weeks. And there's some data, and I think with the IL-28, we probably will start seeing that we'll be able to tailor these patients' therapy, that they may be able to get 16 weeks. So this, in HIV, we're certainly lagging behind that. If you look at the European guidelines, and I would say that generally the Europeans are always ahead of us, and with respect to hepatitis at least, maybe other things like fashion as well, but they in their guidelines do recommend that if you have a HIV co-infected person who's genotype 2 or 3, that as long as they achieve what we call an RVR, which is a negative viral load at 4 weeks, that they get treated for 6 months, not a year. So I actually, although I'm not European, I do follow the European guidelines when that happens, because I think if you can treat these people in a shorter period of time, you give them a better chance, I think, ultimately, of cure, because I think mentally they can maintain the idea of doing 24 weeks versus 48 weeks. And for them, taking the drug is what's the most crucial. They're the ones who do all the work for us. So in terms of, I've given you some numbers already in terms of response to therapy. So these are all of the studies that have been done in HIV Hep C co-infected patients. And the numbers, so I can give you all the numbers, but the real number is anywhere from 27 to 55% of patients who are HIV infected will have achieved cure in terms of response to therapy. So I think I have a comparison here for people that are HIV negative. You can see that in our patients, believe it or not, even though we say HIV-infected patients don't respond as well, the reality is if you look at the middle, which is the Presco study, and you look at the right, which is the HIV-negative patients, we're close. 36 versus 46% for genotype 1s, but for genotype 2s, we're really getting very similar results. So although some people would say, well, why would you treat an HIV-infected patient? They have much less response to therapy. I would say, man, if I were a patient and I was trying to achieve a cure of a viral infection that could kill me, I wouldn't say that those numbers are all that different, and I really don't think that they are. So I counsel my HIV-infected patients pretty much the way that I do the mono-infected Hep C patients, to be honest with you. So the only other thing I want to show you is when it comes to viral load. So I talked about genotype, and genotype 1 clearly having less response to therapy. But viral load is actually a bigger deal than most people realize. And this is one of the very large co-infected studies that was published in the New England Journal. And I know you guys probably can't see these. But hopefully, of the 4 that I've highlighted in the little circles, you can tell that 3 look very much alike and 1 doesn't. So genotype, here is genotype 1. These are genotype 1 patients. These are genotype 2s and 3s, right? These are the guys who aren't supposed to respond to therapy very well. These are the guys who are supposed to respond extremely well. So it's amazing that these look very similar. And what these are genotype 1 patients who have viral loads less than 800,000. So the reality is your genotype doesn't matter if you're genotype 1 as much as your viral load. And I have actually been referred many a patient who have had viral loads of 600, 700,000. They're co-infected and they've never been treated. And yet their chance of cure is probably 60 to 70%. So part of it is just getting these patients access to the drug and feeling comfortable with treating them. This is just showing side effects, but I think you guys probably all know that the most limiting side effects in HIV-infected patients is neutropenia and anemia. Part of that is because a lot of the old ART drugs, specifically AZT, cause significant anemia. All of our new drugs don't cause anemia, and I have very few patients on AZT at this point in time. So the whole issue that, HIV patients are limited by anemia, I think, is no longer true. And again, AZT is contraindicated, so if I get a patient who's on AZT, I just switch them off. And my life is easy. My job is so much easier than if someone tried to treat co-infected patients 10 years ago. Apparently I was born at the right time. So the only other, I think this is my final slide, and then we'll have time for questions, this is an overwhelming slide, and it was meant to be, which is to show you the barriers to uptake of Hep C care in HIV-infected patients. And this slide may be the same for Hep C. I just haven't seen a similar study. So this is out of Johns Hopkins as well. And what they looked at was patients who were HIV-infected. One, how many of them ever got referred to someone for consideration of Hep C treatment? And only a third of them got referred. So of all the patients who were co-infected, only a third ultimately got referred for consideration of treatment. And of that third, 3% actually got therapy. So that's a huge number of patients who we don't know why they didn't get referred or anything like that. But I suspect that part of it is, one, many HIV providers even today don't recognize the significance of it. So to put it in perspective, I think that we have very good HIV doctors here at Duke. I'm biased, but my mentor, Chuck Hicks, who's my HIV mentor, was a resident in San Francisco in the 80s. So he saw this happening. And I think that's what made him go. I mean, that's really what made him make a decision to go into HIV disease. He's been doing it his whole life, and he's an amazing doctor. But if you look at in our clinic, up until 3 years ago, only 50% of our patients had a Hep C antibody test, of our HIV-infected patients. A lack of understanding that this was important. So since I have come on and really pushed for this, and actually other groups, and including a group run by Andrew Muir, who started to look at alcohol use in co-infected and Hep C-infected patients, and ultimately our co-infected patients spilled into that, we've been pushing, and now we have up to 80% of our patients with a Hep C antibody test. But still, 20% of our patients who haven't even been screened, and they're getting care on a regular basis. So part of the barriers, this goes to the barriers of the patient. So they are unaware that there's treatment. They don't even know that there is treatment. So I can tell you that I get referred patients all the time. And I say, do you know why they're here? And they're like, something about hepatitis. And I was like, okay, something about hepatitis. Do you know that you have hepatitis? No. Do you know what hepatitis is? No. So, there's a lot of problems with regards to not only, these patients are getting care, but their hepatitis C is not part of the care they're getting. So part of it is patients don't even know what it is. And then they say, even if I could get treatment, the side effects sound horrible. I heard that, there's lots of out there. The internet, I think, I love it and I hate it because it gives, it can be very biased and people don't realize that. But a lot of patients will come in and say, oh my God, I heard it was horrible, I want nothing to do with it. And I'll be honest with you, a lot of providers think interferon's horrible too. And I think that we don't realize that we can really bias our patients in making their decisions by the way we present it to them. Now, I certainly don't sell it like it's a cakewalk or something that everyone would want to do, but I do try to encourage them, to be honest with you, to get the therapy if I think they're a good candidate. And then here they actually talk about provider evaluations and what is providers' perception of patients, that they won't take the drug, that they're going to get reinfected anyway because they're using drugs, so why should I treat them? And that's probably one of the more concerning things that I find, to be honest with you. There's a reality here, which is that there's never been data to show that if you actively use drugs, that you have a poor response to treatment for hepatitis C. If you use alcohol, there's a very clear correlation. But I can tell you that, so if 85% of my patients are co-infected, then probably 85% of my patients have used drugs at some point in their life. And I can tell you that probably of my patients, 40% are actively using drugs. But I can also tell you that they show up for all their appointments, they take their HIV medicines, their CD4 counts are over 500, and then you have to really query, okay, they're using drugs, and that's something we need to work on, because clearly that's bad for them. But should you necessarily exclude them from therapy, or even the consideration of therapy, because of that? And I think that's something that different groups have different opinions. But I think this is a big problem, and we still have lots of patients. If you look at our patients, so I've started these co-infection clinics that are multidisciplinary. I work with a GI doc, a hepatologist, and in that we also demanded and got, luckily, a social worker, a polysubstance abuse counselor, and a psychiatrist. So when we do co-infection therapy, we do it as part of a multidisciplinary approach because we do believe that, one, asking a patient to go to multiple doctor's offices so they don't know to get different therapies from different people doesn't work. Two, it's about trust. And if they feel safe in that clinic, and if they feel that they can get the care that they need, whether it's their psychiatric care or their substance abuse care or their Hep C care, their HIV care, they have a better chance of showing. And we just started it, so it's now 7 months into co-infection clinics at both sites. But we do hope to publish the data, and I do hope that we see good signs. And I think that what we'll find is that at least one, people are getting educated. They may be getting more access to polysubstance abuse, and probably, at least by my experience, we're treating a lot of them. These are people that have had Hep C for 20 to 30 years. So anyway, so that's the sunset across the Kenyan Serengeti, and I will take any questions and an open discussion. Yes. Did you want to? There you go.
There we go. You made a comment about the fact that Duke isn't offering transplant, and I think you meant to the co-infected patients specifically.
The HIV-infected patients.
Oh, to the HIV-infected
Correct.
patients. And could you talk a little bit about what the rationale is and whether that rationale stands up in the literature?
Yeah. So I don't do transplant, but I can tell you that, one, we do a lot of transplants here at Duke, and that there is one transplant group in particular who is having discussion with the ID division to develop a protocol for transplant of HIV-infected patients. It's a certain organ group that's working on that. So I can tell you that, one, for renal transplants and heart transplants, HIV-infected patients appear to do just as well. So I think that's probably ultimately why, when you look at sites that are willing to offer transplant to HIV-infected patients are primarily willing to offer those. If you look at liver transplants alone, there is literature out there to show that patients who are HIV-infected do not do as well. That being said, they do better than if they're dead. So, I mean, it's not that they don't do as well compared to the Hep C mono-infected cohort, but it's not dramatically worse. It's definitely worse. But I imagine if you looked at some of the patients that we transplant, and if you actually pulled out the mono-infected group by age or something, another group that may be a little higher risk, but they're okay with everything else, so they get transplanted, they'd probably be equal. Does that make sense? So we know that when people get transplanted, there are all kinds of things that we consider. And I think if you took an HIV-infected patient who, in and of themselves, their age and everything else was great, they probably would be equal to most of the older patients or the patients with diabetes or whatever their other complications are that are getting transplanted. But clearly right now, people would say that the literature supports not transplanting those patients, the HIV-infected patients. There are sites that do, who believe that while there is a difference, it's not a difference enough to say that those patients don't deserve a chance at transplant. Yeah.
Study for the I worked at a centre where we had the NIH liver transplant program.
Transplant study?
Yeah, and I haven't heard on any, apart from the Hep C patients do worse, but
Right.
I was just wondering if they were.
So I haven't seen it published, and there hasn't been much published in HIV liver transplant that I know of at all. But I haven't seen anything come out within the past year. But I can certainly look and see. So you know that there's one coming. I wasn't aware that there was even one coming, so that's actually good to know. So we'll see. That's it? You guys let me off the hook? Excellent. Thank you for having me.